Okay, so we've got plenty of questions to cover just between you guys here. So one of the first ones I want to start with, David, is that you got a lot of questions asking about some knee bracing and taping techniques. Some people were confused. How do you pick between the two? Do you switch between them? Should you be switching your bracing options? What do you do if you can't tolerate one or the other? So I'd love you to speak on some options between taping and bracing decisions.
Yeah, that's a good question. I tend to start with the least restrictive one possible. So if somebody doesn't need a leukotape, then let's use a kinesiotape. If they don't need a kinesiotape, let's try to do nothing. I want you to have as little external support as you need to be able to do what it is that you need to do. I don't want to overbrace. If we tried the tape and the tape is not enough, or maybe the tape is successful and they don't want to tape themselves every day or every time they go out to the store or something, okay, try a sleeve. If the sleeve works, do you like the one with the hole or without the hole? If you try that one and that's not enough, then maybe you get one with stays on the inside and outside. They have some that have a plasticky, rubbery flexibility component to it. Maybe we start with that one, and if that's not enough, maybe we get something with a metal stay on the inside and the outside if you need even more support from that. So ultimately, it's an individual basis decision, but I'm always looking to say, what's the least amount I can give you and that you can be more comfortable to do what you need to do on a daily basis?
Great answer. I completely agree. And Marcia, actually, a lot of people related to what you were saying about the hand being the limiting factor for some exercise, whether that be in yoga or weight-bearing activity or weightlifting. So there was a couple questions in here that I wanted to touch base with you. What are some good accommodations that you've found if people need to weight bear through their hands, or all of the examples that you gave and they have trouble with those hypermobile hands?
So very good question. I am an Ashtanga yoga practitioner for the past, I'm not going to say it, it's going to turn in my age. We don't talk about it. So before I could practice, I had no issues. I always had issues with my hands. But for the past 3-4 years, what I have to do is actually, so I have a special thumb sleeve that I have to use to prevent my dislocations. I also wear a compression glove as I practice. And there is there is a wrist widget, which I love because I don't have my ligaments at the distal wrist anymore. So the wrist widget is great because it keeps together the distal two bones on the forearm. And what it does, it allows me to generate force again through my hands, because without it, I have no way to press down. And lastly, there is it's like a on-the-go mat. It's a glove that I put on top of it, so it increases the padding. So now I have the padding on my mat and the padding of that glove. And for the weight training, I am already on the weight phase and I lift. I use a special strap glove with a strap that allows me to have the leverage to hold the weight, because I can't hold the weight, because you guys will notice that it will distract the joints if you try to hold a weight that is a little heavier than your ligaments can handle.
Great. I also love that wrist widget. I find that really helpful for patients that have trouble leaning on those hands too.
Definitely.
So this one can go to either of you guys, but we had some questions about crepitus and some sounds that can come from the joints, and when you need to back off when you hear those sounds, if they're normal, if it's okay to work through. So what are your guys' thoughts on the grinding, the popping, the clicking that a lot of patients with hypermobility have when they exercise?
So number one thing I think you have to think is, okay, is it popping, is it grinding, and it is painful? Obviously, if it is painful, stop. Second, if it is popping, if it's cracking, is that an adaptation you have to do on the position? Are you utilizing your muscle correctly, right? So maybe you are not firing the muscle correctly. Maybe your joint is not seating correctly. So I would stop, and it's on very individual basis too. I pop and crack every time I move. If I would stop moving every time I pop and crack, I wouldn't just sit still. So it's more of, okay, am I utilizing, if you're exercising and strengthening, am I utilizing my joint in the correct position? If your shoulder sits off the socket, is it sitting correctly, as you learned on the lecture a couple days ago? Is it in the right position, and now can you activate your muscles correctly? But it's essentially painful, don't stop, rethink the movement, or abort that exercise and rethink that another exercise completely with your therapist, or rethink what you are doing. Do you need support, bracing, taping? What do you need done for that?
Yep. And I would agree with that as well. If it's painful, then we don't need to continue doing that particular maneuver. So we need to modify it in some way. So it may not be that we have to get rid of it, but it's certainly something that needs to be adjusted somewhere. And that's where working with a knowledgeable practitioner really comes into play. So if we use the shoulder example, if someone has clicking and popping when they reach, when does it click and pop? And is it on the way up? Is it on the way down? If I add stability to something, does that make the clicking and popping go away? If I do stabilize it and it still continues, are we able to get what we need to out of the exercise? And is it contraindicated for us to continue with that? Or do we have to take a step back? If we try an easier version of the same thing, do you not get any clicking and popping with that? Is it unsettling for you? So some of that depends on your opinion of the clicking and popping, even if it's independent of the practitioner saying, like, it's fine for you to do, but you can always work through an easier version of the same thing, especially if you don't get any clicking or popping symptoms in that moment.
Yeah, I think one component, just a quick add-on, is that closed chain component, right? Because the open chain might be more clicky and poppy. Once you actually utilize the closed chain and you actually press into the ground with the ground reaction force that I spoke about, you might realize that you get better muscle activation, you might get better stability to the joint and decrease the popping and clicking. So that's another thought.
Awesome, great answers. And so we have Patrick with us now. Hi, Dr. Agnew, nice to have you here. And we had a couple questions for you. A lot of people had questions about Morton's neuroma. So I was wondering if you could talk a little bit about that and what some intervention ideas might be for people who have Morton's neuroma and that hypermobility.
Hi, I'm not surprised to hear that that's a problem that afflicts people with hypermobility. The theoretical basis is that it's kind of like a tiny little carpal tunnel syndrome. There's a ligament connecting the metatarsal heads together and an intermetatarsal nerve that passes on the bottom side of the foot under that ligament, and it gets compressed and irritated. It's misnamed. It's not a neuroma. It's plantar nerve compression syndrome is the more accurate term. I think a big mistake in treating it is to surgically remove it if you don't have to, because when you do cut it, it becomes a neuroma, a thing called a post-traumatic neuroma. So the stump where you cut the nerve off can become symptomatic. You get higher success rates by injecting it with dilute alcohol. We take anhydrous sterile ethanol, dilute it in a local anesthetic to about a 4% solution and inject it around the nerve. The Schwann cell, or the insulation around the nerve, is mostly fat. It absorbs the alcohol, it desiccates that alcohol, and that nerve dies typically after about 3 shots. That usually works 89% of the time, whereas surgical removal is only about 80% and can leave you with a stump neuroma. And it's much more complicated. You have to go back in and do epineuroplasty, which is a microsurgical procedure that not all podiatrists do. But yeah, that's it in a nutshell.
Very helpful. Thank you so much. Something else that's coming up a decent amount in here, people are asking about a shoe lift for scoliosis or if they feel like they have uneven leg lengths. And so I'd actually love to open up answering this question and then ask your opinion if you guys agree. I would find that it's very important to find that you have that stable pelvic ring like we were talking about. Sometimes that can lead to the legs seeming like they're different lengths. So I wouldn't necessarily advise it to put a shoe lift in a shoe if you haven't had your pelvis evaluated properly first. So if you have that pelvic ring, and I'll hold it this way so you guys can see a little bit better, and it tilts backwards, this leg has now been brought that much further away from the ground and it makes that leg seem a bit shorter. So that can be something that would complicate the decision if you want to put a shoe lift in. And if it's a dynamic changing issue, we might not want to put a structural change in there. So do you guys have any thoughts about shoe lifts if people feel they have that scoliosis or an uneven leg length?
So there is a place for everything, I
Absolutely.
believe, but I agree with you. I rather make correction to the pelvis, analyze what is necessary, and if there is something that needs to be corrected, and everything goes right back to it, right? Muscle memory goes right back to where it's used to be. So teach the patient to take home that maneuver and to be able to correct himself or herself. And if there is a more structural change to the point that we can now not change, there is an arthritic process now that nothing can be changed, that's when I recommend the lift. But that's about, I go about the same as you do.
Okay, great.
Yep. And I would agree. That's something that I've played with, and especially in the last year of practice, we do see a lot of scoliotic patients that come in the clinic. So with my training and background, we would have people do a standing forward bending test and see what they can do comfortably. Does it hurt? Where does it hurt? How would you rate it 0 to 10 wise? And then we can do a palpation assessment to see if there is any sort of rotation, either from the PSIS with how one segment moves more in relatives to the other. We can check that from the front. So we look at ASIS height, ilium height, and then we also look at the ankle as well. I use a neutral talocrural positioning, and then I see what effect that has up at the top. So if I put you in a neutral foot, does that change my palpation? And then can you hold that? So if we get that improved and then we reassess the bending, we need to see, do you need a space in between the foot and the floor? So I'll use a stack of computer paper where if there is what I would discern as a structural deficit, that they need more height in that, then I'll put a stack of papers underneath the short foot in order to bring that up where it's equal. We reassess the height, and then we reassess that forward bending and standing and see if that improves symptoms. And obviously, standing and forward bending is not an all-inclusive thing, but it can give us a piece of the puzzle to see, do we need to consider a shoe lift? Can we do something with your arch and get away with that? And if you need a lift in your shoe, as in something to space the heel up, we definitely want to lift the actual shoe itself and not just put a heel lift in your shoe and leave you in that. So that's another nuance, I would say.
Definitely a good point. I agree. Go ahead,
I agree with everything. I agree with everything that's been said. I mentioned that in order to really accurately measure a structural length difference, usually requires a scanogram, which is pretty much a head-to-toe X-ray measured, a big dose of radiation, and probably impractical. So and you can only lift so much with a shoe change, maybe a centimeter or so, and then you have a shoe that's no longer functional. But any change you make, like a lift in the shoe or a lift of the shoe itself, in the sole of the shoe, built in by a shoemaker, it needs to be gradually accommodated, or you need to get acclimated to it. So you wear it maybe an hour the first evening between supper and bedtime, 2 hours next night, 3 hours next night. Don't wear it out on the street for a solid week. This probably goes for any new footwear, any new shoe you buy. You want to gradually get used to it. That's it.
Awesome. Thank you so much. And so I have a couple questions here as well of how might some of these interventions, and all of us talking about it in different ways, whether it's surgical, bracing, exercise, how might those change with other comorbidities, say something like tethered cord syndrome that often accompanies EDS?
So for tethered cord syndrome, for example, or any other comorbidities, you have to assess the patient and see what is available for us to work with, right? So with that tethered cord, sometimes straightening the knees is an issue. For tethered cord, sometimes bridging might be an issue. So we need to analyze and see what a patient can and is able to do, and essentially find out, is that a patient that is going to be heading down the road to surgery, and this is a pre-op program, versus this is something that's trying to be managed conservatively. So the protocols will change. Essentially, we want to work away from pain, away from the pain site when necessary, and away from generating more pain and tissue irritation. Because if we keep moving, you guys, and creating, it's okay to feel a little sore after an exercise session, but we're talking about muscle sore. If you guys develop back pain, if you develop any other changes, like you develop, I don't know, changes in bladder behavior, changes in other functions, that is not okay. That needs to be reassessed. So the prescription is made specifically for each and every case.
Very well put. I agree. And monitoring those symptoms as they change. And so this one's a loaded question, and again, can go out to anybody. But you were talking about that soreness, and it goes hand in hand with the fatigue. So how do you manage the fatigue that comes after exercise or after joint alignment changes, and how people respond to those changes? And how do you know when it's okay to start these things back up again, or how long of a break you really need to take?
Yeah, so I cue people to, especially when they're first starting, I want somebody to do one body region per day of the week. And so each day is a different part of the body to establish that consistency like you described in yours. People need to be in the habit of, if you miss a day of working out, you should not feel good because you're like, something is missing. What didn't I didn't work out today. And that should create a response, essentially, that is driving that change of behavior, which is what we're really after. So to me, I tell people, make Monday neck day, Tuesday's knee day, Wednesday's back day, Thursday's foot day, Fridays, and make it whatever you want. But the idea is to start somewhere, do something, and then build yourself up over time. You will know the difference between replicating the symptoms that you're seeking treatment for versus, oh, I can tell I moved that muscle one or two too many times. So then, if your soreness is gone, the next time you go back to do the same workout, keep your sets and reps, the resistance the same, and gauge your response then. If you're still sore by the time that comes back around, you need to cut the intensity or the sets or the reps by 20% and start with that. Then see how you feel from there. That way you're chipping away a small amount, but at least you're doing something to speak to that change that you feel.
Awesome.
Yeah, and I think also we have to think is that our lives are not just revolving around exercise, right? Our lives have other things going on. So there is that day that you have to do laundry, fold laundry, cook, clean, empty the dishwasher. Those are all exercise. Those are all physical activities, right? So we need to take into consideration what you're doing that day. If you have a doctor's appointment where you have to walk from point A to point B, which is really far, that might have been enough for you. Each one of us is at a different level. So try to equate what you are going to do with your exercise program along with what you have to do on that day. That's very important. How you wake up in the morning. Did you sleep well? That makes a difference. That changes your recovery rate or change the recovery rate even from the overnight waking up in the morning. And then you also have to think about how did you eat? Did you get a decent meal? Are you being able to nourish yourself correctly? For those that are not even, that have a very limited diet, you have to take that into consideration as well, because your recovery, you don't have enough building blocks for your tissue, so now that makes you have to peel back even more. So recovery and how you feel that day all counts.
Absolutely, I agree. Well, thank you guys. All of you did amazing. Patrick, Marcia, and David, you guys have some incredible insight, and it was wonderful to learn from you all. So thank you all for your questions, and we are on our way.